Okay, so thank you very much, Sheila, for inviting me to Knee Guru. Today, I'm going to talk about cell therapy in osteoarthritis. As Sheila say, I am an orthopedic surgeon and I am a professor in sports medicine as well. I have a great interest in regenerative medicine and non-surgical intervention for osteoarthritis. So here is our presentation. Here is some key learning points I want to talk about tonight. It is, first of all, we want to talk about the basic of cell theories. What are cells? What do they do? And the anatomy of the cells. How do they arrange inside our joint? How will cell therapy work? And how does it work in practice? So before we go down to the nitty-gritty of the cells and how they work, let's generally talk about osteoarthritis. We know that osteoarthritis is a degenerative condition of the joint. It is a very complex process, and there are many factors influence its progress. Swelling and inflammations are a result of arthritis, not the cause. And actually, the cause of the osteoarthritis is not fully understood. All we know is it is very common and is commonly affecting the knee. So I got some x-rays here. You can see on the x-ray on here, this is a normal knee joint. You can see the joint space there is pretty open. And you can look at this side. This is the arthritis. You can see the joint between the joint. There's nothing there. The bone is rubbing against bone. And some surgeons or some patients would term this bone-on-bone osteoarthritis. If we look at this diagram here, we can show that this the bone is rubbing against the bone. The cartilage is worn off. And this is what a representation of osteoarthritis. So we talked about the pathophysiology. The next thing we want to talk about is what is the symptoms of osteoarthritis. So you may suffer from pain, you may have stiffness, especially after you've been sitting down for a while, and you sometimes have some cracking, crunching, and clicking and grinding sensation in the joint. And some patient will feel a hard lump around the joint. Now, these hard lump could be what we call osteophyte, and some people term it bone spur. And this is a part and parcel of the osteoarthritis. And sometimes you will have swelling that is, soft swelling. So this is basically a fluid inside the knee that is forming a little pouch, a little cyst. Something that is commonly experienced by patient is Baker's cyst, which is a cyst that forms behind the knee. It is sometimes caused by osteoarthritis as well. There are some other symptoms that it could be the knee be giving way, and the knee could become bow or become bent. The muscle around the joint become wasted. So these are the typical symptoms of osteoarthritis. So what we're really interested today is talk about the treatment options. So there are different treatment options. There are a surgical treatment option, and there's a non-surgical treatment options. Non-surgical treatment option doesn't just involve in pills. Bracing is extremely useful, extremely important. Of course, you get your standard painkillers, but they are different modality. Also, we can do injection therapy. With these combination, we can treat osteoarthritis successfully, and we can, if we use it in the right modality, we can delay or even make people to not have surgery at all. Now, of course, there's surgical interventions as well in terms of knee replacement, that including keyhole surgery, open surgery, osteotomy, replacement, all sorts of things. But we're not going to focus on that tonight. So in terms of the treatment options, we can either regenerate the joint or we could replace the joint. Now, regeneration, if we want to look into that, we need to look at cell therapy. There's only one thing that in our body that can build and regenerate is our own cells. So this is what I'm going to focus a lot on tonight. And alternatively, if all the cells fail, we can always put metal and plastic in. So cell therapy. This is a very interesting slide I would like to share with you. This is a scan electronic microscopy of a capillary. So you can see these red little things here. These are cells. These are what we call perivascular cells. I will talk about the importance of these cells later, but right now I'm just going to share with you these pictures, and you can see that these cells are they do actually exist. So let's talk about arthritis. before we can go down into the detail of cell therapy, first of all, I want to talk about the very basic, about what sort of cells we got in our knees and in our cartilage, and I will pick the knee to start off. So looking at this knee joint, inside there is the inside the knee joint, there is cells within the cartilage, and if you do a cross section of the knee, that's what we can see. At the top layer there, so that is this part here at the top is the articular cartilage. At the bottom part here is the bone. Now, so at the very, very top of the articular cartilage, you can see the fiber outlying here are very, very parallel at the top. So they are very, very good for gliding and give it tensile strength. And then you can see the middle layer there is all crisscross. With this crisscross, it gives the strength within the cartilage. And you can see the cells within these within the cartilage. Now these are the cells that we are really interested in. So these are the specialized cartilage cells. We call it chondrocytes. So these are the specialized cells that will create cartilage. They will use our body's collagen, and then they will use proteoglycan, and they will get the water to help to form this cartilage. So that is the general anatomy of what our cartilage look like. One very important thing I want to bring to your attention is this tie mark here, tie mark. So this is the line here, is what we call tie mark. So this is a natural barrier that we have got between our bone and our cartilage. The reason for this tie mark to be there is to separate between the cartilage surface and the bone surface. So nature tells us that we do not want the bone to cross into the cartilage side. Now, this is quite important concept to have, which I will talk a little bit more later on, why they're so important and how we can treat arthritis with regenerative therapy logically. So after we talk about the basic cell anatomy and the cartilage anatomy, I want to talk about the principle of regeneration therapy. In order for us to regenerate any cells or any cartilage, we need to be able to think in 4 different modalities. We need to make sure the cells, so the seeds as such, the cells are good, so they are viable, they are alive, so they can grow. We want to then give them an environment, a scaffold for them to anchor themselves in, and then we want to give them enough nutrient in our body. We call these growth factors. So and then finally, we want to make sure the mechanics around the body is good in order for this regeneration to be successful. I would like you to think about it this way. Regeneration cell therapy is like planting a new tree. We need to make sure we got a very good seed, very good soil, give them nutrient, and sometimes we will have to give them some mechanical support to guide its growth. So this is basically what we are doing in the human body to regenerate. Now, before I go down to the detail of different type of regenerative therapy and cell therapy, I want to talk about a very common thing is a corticosteroid injection. It is something very, very common that has been used to treat osteoarthritis of the knee. It is very common if you go to see your general practitioner or your general doctors, they will say, yeah, we'll give you a cortisone shot and take your knee pain away. Now, I want to challenge this with some science behind it. Corticosteroid is extremely acidic. They are poisons to cells, and if we inject corticosteroid into a patient's knee, we tend to mix it with local anesthetic. Local anesthetic is something that we use in the lab to kill the cells. So to me, injecting a acidic substance alongside with something that we can use in the lab to kill the cells, injected directly into someone's knee, make absolutely no sense. This diagram here, the green photo here that I'm trying to show is an experiment that I have done. So I took a piece of human cartilage following a knee replacement, a part of the healthy cartilage we took out, and we took into the lab and we put some steroid onto the one that we used to inject patients' knee. We put it onto the cartilage, leave it for a few hours. Then we do what we call live dead staining. So on this screen, with the cells, the red stuff there, the cells, if they light up red, that means the cells are dead. If they are green, that means the cells are alive. So you can see within this slide here, so these are, most of the cells are dead. You can see one or two, green ones still about, but, this is the effect that, it will have in the cartilage if we inject corticosteroid. Now, there's a very, very good review done by the Cochrane group, which is one of the highest evidence that we can get. It suggests that we should not use steroid to treat osteoarthritis. It really makes no logical sense at all. So, if I say we shouldn't use steroid, what should we use instead? So the stuff that I tend to use, we will think about how we're going to deal with this biologically. If you remember what I talk about, within the cell therapy, we want to make sure the cells is good, the scaffold is good, and we want to give them nutrients, the growth factors, and the mechanics. So in a very early stage of osteoarthritis, the cells within your knee is still good. The soil, the scaffold is still good because there's not much damage in it. We just need to give the knee some nutrients and some growth factors to actually enhance its recovery. So this is something that I tend to use. It's called platelet-rich plasma. So what does that mean? Is essentially is we take some blood out of your body, we put it down to a centrifugation machine, we spin it down, and then we separated the red blood cell at the bottom and then the serum at the top. Now, the really interesting part is the middle part here between the serum and the red blood cell, because this is where in the middle, this is where all the platelets sit and all the growth factors sit. Now, there are many studies and show that there are very, very powerful growth factors and very powerful anti-inflammatory factors that sit in that layer. So you can see on this graph here, on this table here, is talk about the growth factors that we show under ELISA, which is something that we use to look at which growth factors that is in the sample. So you can see this PDGF, AB. So what PDGF essentially stands for is platelet divide growth factors. So you can see there are plenty of growth factors there, and also there are quite some of the very powerful anti-inflammatory cytokines and substances there. And the beauty is these are from your own blood and your own body. So this is something that I often use to enhance my treatment for patients with knee pain on early stage. Now, in terms of evidence, how much evidence do we have in terms of using PRP, and how does it actually really work? We say you got some growth factors, you take the middle layer out, but how does it actually work? So research has been done. If you want to get down to the very, very nitty-gritty, it basically is enhance the superficial zone protein, and it decrease the coefficient frictions and increase the proliferation of the cells. So what it actually essentially mean is it just make the knee have less friction within it. And also it make the top layer where the cartilage is, it just make things grow a little bit and calm things down a little. Now, in terms of clinically, how does it also work? There are paper to show that they have an anabolic effect to the cartilage and a catabolic effect to the inflammation. So basically, they stop the inflammation and they actually rebuild the collagens. So next thing is hyaluronic acid. There is another common stuff that I use to treat as an injection therapy to the knee. It is, again, a very useful substance. Now, strictly speaking, this is not cell therapy because hyaluronic acid is fully synthetic, at least the one that I use. And there are some hyaluronic acid is derived from animals, but the one that I tend to use is fully synthetic. And what is hyaluronic acid? It is basically scientists have looked at what the knee synovial fluid, the fluid inside the joint, what is it? And then we mimic that from the lab. We actually cracked it. We know the equation of what this substance is form of, and we actually made these substance again. So we call it hyaluronic acid. And so it does have a basically, if you think of it like an oil change within your knee. So it would give you some synthetic oil in there. It reduces the inflammation around there, so we can wash off some of the old inflammations inside the knee. And it is the molecular size is quite big, so which means that it has some sort of cushioning effect around your cartilage as well, which is a very, very powerful tool that we tend to use in cell therapy alongside with our cell therapy to enhance the effects of our cells and our growth factors. Now, with hyaluronic acids, there are 32 randomized control trial in the world that have suggested that just by injecting that is better than placebo. So there's plenty of evidence out there for hyaluronic acid. Now, what do I think? How should we use hyaluronic acid and PRP? I think we should use them together. As I explained to you just now, PRP have its function. You got your own body's growth factors, anti-inflammatory, and with the hyaluronic acid, you actually provide some sort of nutrients, some sort of lubrication around the knee. So I think if we can inject the both of them in combination, it really will help our patient. And recently, we have a very good example from one of our patients. She had the injection. She went for a 26-mile bike ride the day after, and she absolutely delighted with it. So these are some of the simple injection therapy that I talk about. So for the next few minutes, we're going to talk about the actual cell therapy and enhancing our body cells. Now, before I go down there, of course, I need to talk about a very important features. It's treatment that sometimes orthopedic surgeons do is microfractures. So this is microfractures. If you can see this on here, this basically showing that within the knee joint here, the cartilage is worn away. There's no shiny cartilage surface. And you can see on this view here, the white bit here is a shiny cartilage surface. And on here, we have made some microfractures hole within there. So microfracture is forming divot inside that bone. So the belief is that the traditional teaching suggests that the blood will start leaking out from these holes, and from there, all the stem cell will leak out, and it will form what they believe is fibrocartilage. So these are a typical example from a textbook, and that's the traditional teaching on orthopedics or sport medicine. So that's what people tend to be doing for the last 10, 20 years. Now, I would like to challenge that thought. If you remember how I have explained to you about the layers of cells and the way the cells are laid out, which I'm going to show you on the next slide. So there's this tie mark there, and with this microfracture, we're deliberately breaking this tie mark. Now, to me, this doesn't make very much logical sense, the way that how we used to treat this cartilage lesion within the joint with microfracture. Because one thing for sure is that a fracture in a bone will heal with bone. Fracture healing from bone, as you can see on these pictures here. So this is a bone here, so it was fractured, and then you can see this white stuff around there. These are bone formation, so we call them callus. So this is a very, very clear model of how the bones are healed. They form soft callus, and then the soft callus become hardened, and then become bone. They become remodeling. So it makes absolutely logical sense that when a fracture happens, bone will form. Now, to me personally, I don't think it makes very much logical sense if we're saying that we go in there and break through that tie mark, as you can see on this diagram that we had before, and we would expect the stems only the stem cell come out from these little holes to then fill this hole and form cartilage, which are quite a silly idea, I think. But it is something that has been done for a very long time. There is good clinical result in some of patients, but in terms of cell therapy, I do not think that's the best way forward. As I say earlier on, there's only one thing in this universe can create cartilage, and that's chondrocyte, specialist cartilage cells. The only way we can find the chondrocyte is within the cartilage itself, or maybe a stem cells can develop themselves into chondrocyte, but we need to guide them carefully. So this is some of the controversy that and some of the logical thinking behind cell therapy. So now let's talk about the cells itself. There are different types of cells. We talk about chondrocyte and stem cells. We must not forget about fat cells. Fat cells are actually quite important. And if you can see this diagram here, on the first picture that I show you, the scan electron microscopy with the cells of the pericyte on the capillaries and these cells. So here we go. These are the capillaries. So these here are the pericytes. So there's some new evidence suggests that the pericytes around the fat cells, they can actually change themselves back into stem cells. And then from the stem cells, they can then turn themselves into a cartilage cell. Now, this is a very, very new theory that we can be able to enhance this perivascular cells to change themselves into a cartilage cell. It happened in the lab, but does it happen in the human body? It is something to wait to be seen. Now, so this treatment is called lipogem, and it's something that we've used a few times. We basically take the fat, we have microfraction it, and then we inject into the joint. Now, to me, this serves two purposes. The regenerative potential with this potential, the peri side that I talk about, that's one thing. It could happen, it may not happen, but actually the more important feature with these fat cells here is that they are forming a very soft layer between the two damaged surface. If you remember the X-ray that I showed you before about the bone-on-bone surface, so by injecting a bit of fat in there, we actually are stopping these two bone rubbing together. So it does have some mechanical benefit. So, but whether that will recreate the full cartilage or not, that's waiting to be seen. I think it may be a big ask, but there are some scientific basis on it. There are some lab studies show that it can, but on a human and within clinical practice, that's to be seen. But at least it does work with this lipogem injection, and patients are usually very happy with the outcome because they don't have the pain anymore. At least we have so far data for up to 2 years, and we will continue to follow that. Now, the next thing to do is the real stuff, the real cell therapy, what we call ACI, which is stand for autologous chondrocyte implantation, which is a bit of a mouthful. Autologous mean it's coming from your own body. Chondrocyte, which is the cartilage cells I was talking about. Implantation, putting it back in. So what it is essentially, if you look at this knee here, so you can see the red bit is the lesion. What we can do is we can take the blue stuff there, which is healthy cartilage, on the very, very outside of the knee, which is the non-weight bearing area. So, and then we can take that and we put them into the lab, and we can take it to cultures. We expand them into 6-7 million of chondrocyte, and then we then have second surgery 2 to 6 weeks later, and then we put it into that hole and we fill that and we cover it with something. The old traditional way is cover it with a periosteal flap. So by doing that, there's some good result been shown, and this is proper cell therapy because as I say to you, there's only one thing that can create cartilage, and that is chondrocyte. Now, this is a technique that has been popularized by the late Professor James Richardson, who I had the pleasure to work with in the Robert Jones and Agnes Hunt's Orthopedic Hospital in the UK. And there are over 20 years of clinical history and pedigree of this sort of treatment of the cell therapy. You can see at the top there, there's so many different letters: ACI, MACI, AMIC. So they all stand for different things. So I have talked about the ACI already. I'm going to talk about the next thing we're going to talk about is MACI, MACI. So what MACI stand for is matrix-induced autologous chondrocyte implantation. So the ACI is the same, but we're just putting a matrix on, so matrix-induced. So if you remember my slide, talk about the 4 important factors. So on this part here, instead of using a simple periosteal patch, we actually use a specialized matrix that can help us to hold the cells, to give the cell a better environment, the proper scaffold to get the cells to lay themselves on, to integrate with the body. So this is the next level, the next generation of ACI. So we call that MACI, MACI. Now, with the ACI, we have to do it in 2 different stages. So first stage is we go in there, we take the cells out, so that's stage 1, and then we have to grow those cells and then put it back in, so that's stage 2. So we often need 2 surgery. The later development to this technique is called AMIC, AMIC. Again, this is quite subtle. It's a subtle difference. So in this treatment option, we no longer use chondrocytes anymore. So this stand for autologous matrix-induced chondrogenesis. Now this is quite important, the word genesis, because we are creating chondrocyte. We would like to think that we are creating chondrocyte. So again, the matrix is again with the membrane, but how are we going to generate or genesis, create this chondrocyte? Is by doing stem cells. So with this, what we tend to do is we will do a bone marrow aspirate for about 60 mils, and then we isolate the stem cell from the bone marrow. Now, with these bone marrow stem cells is what we call mesenchymal stem cells. With 60 mils, at best, you get 1 to 2 mil. So with that, and then we put that into the membrane or the matrix that we talked about, and then we do the same thing, put it back in there. The benefit of this is it doesn't involve a laboratory. It all can be done in one sitting. Results are also promising. So here is some of my results. So this is one of the cases I did about nine months ago. So this is a patient that have a kneecap dislocation. You can see the salient features here is that a bit of cartilage here. This is the kneecap at the top, and this is a bit of cartilage here. This black bit here has been chipped off, and then by the time we get to it, that cartilage have been destroyed and melted away. Because he's only 23 years old, we have done a cell therapy procedure for him, and also fix his kneecap as well. So we can see the cartilage now has like come back, and there is a cover there. The next case that I'm going to talk about is another case that we have done. That's approximately 6 months ago, and again you can see on here on the femur. So on the top, this is the femur. This is the tibia at the bottom, and the kneecap is somewhere around there. So the important part here is that you can see the cartilage is gone. There's a big gap there, and there's nothing, there's nothing there. So this is a very important weight-bearing area. So again, we have done cell therapy. We use a membrane, and it has, and you can see here, this is now grown back, and we have got the cartilage layer back on there. And you can see there's bone reaction at the top here. And within this bone reaction, means that the body is actually uptaking these cells and actually remodeling around that side here. So here we go. So this is just a very brief introduction to cell therapy. And my view in the future, in terms of treatment, is we should no longer do microfracture. We need to enhance our body healing potential. We should use PRP with hyaluronic acid. Perhaps we should start using fat cells as well. It does take the pain away. It does have very good outcome, but does it regenerate? We don't know yet. And also, I think there are newer ways that is coming along for us to help us to improve the cell therapy in terms of ACI. I think that will be the future of cell therapy. Thank you.